So I'm Amy Esler. I'm a new hire to the ASD clinic at the University of Minnesota, working with Robin Rumsey and Dr. Michael Reif. One of my first jobs after graduate school was working as a school psychologist in the St. Croix River Education District up north, a little ways. But I first started out as an aide to children with disabilities, many of whom had autism. So I've done a lot of things in this area and now moved on to mainly focus on diagnostic assessment and behavioral and early interventions for kids with autism. So my intention today is just to talk about interventions for ASD, focusing on the most common ones out there. I'm certainly not going to give you an exhaustive list, but just to sort of familiarize you with what all these terms mean and what we know about them in terms of their research support. I had the good fortune of working on a study with Rondi very briefly at the University of Wisconsin, where I was before I came here. Fragile X, it was word learning in Fragile X and autism. So there's a lot of really interesting language-based research going on in this field as well. Okay. So Rondi talked a little bit about this too. Autism is a neurobiological disorder. So we define it basically on behavioral criteria, and the criteria, which are in the DSM-4, were pretty much developed by a panel of experts. Many of them were developed before we had a lot of hard research on what the features were. So it's a consensus diagnosis. It's not, a diagnosis like diabetes is. So, and it's also a changing diagnosis. The DSM-5 will probably have a different way of organizing the symptom areas of ASD. For example, the current criteria don't work very well for kids under 4 who wouldn't necessarily have a best friend yet, may not even have pretend play yet. So some of those things need to be adjusted. We don't have a neurobiological marker, as I said. We're finding out more about genes that may underlie the syndrome, but even when we find an abnormality using CGH, just a little deletion or a duplication, we really don't know how often things like that occur in the general population. So it's hard to really say this is the reason this child has autism. We found a genetic abnormality. I mean, we all might have some of those. So what I want you to do, though, is imagine, so what kind of underlies this whole presentation and thinking about which interventions to choose or which to recommend. Imagine if your child were given a diagnosis of autism, and some of you don't have to imagine that, it's happened to you. There's not a cause known. We don't know why it happened. It could be you're the first person in the family to have a child with autism. It's really hard to feel a sense of control. We don't know why this happened, but it happened. We don't really know what might occur. At age 2, we don't know exactly, who's going to turn out to be a high IQ kid with autism or a child who never learns to speak. And in some cases, we don't know exactly what you can do to make sure your child has the best outcome. So often, last year and the year before that, I was seeing all kids with autism age 2. So I almost always was the first person to give the diagnosis. And that was hard. I did that 3 times a week. It's very stressful, but imagine what it was probably like for the parents. And so it was a longitudinal study, so I got to see them a year later. I have some friends who I've worked with who have children with autism, and sort of in talking to them, a lot of what seems to go on as they're sort of processing the diagnosis is, they have feelings about how long they waited before they got help. They might have had concerns in the first year of life, but just wrote them off. And even if they come to see me at age 24 months, which is really, really early, they still think, well, why I should have come at 12 months and we would have had a year of intervention under our belts. They wonder, could I have prevented this? Could I have caused this? I've had parents ask me things like, I was on an antidepressant before I realized I was pregnant. Do you think I gave this to my child? Parents are new to this. They're not people who have lived and breathed this the way that, people like me have. So they don't always know what they might have done to have their child develop autism. Then they go home and they're faced with all kinds of information. In Wisconsin, I gave them all these numbers to call because there was a waiver system where if you had a diagnosis of autism, you could be on this 2-year waiting list to get basically free early intervention paid for by the state, 2-year waiting list. But you could get it if you waited long enough. When it was originally developed, you could get it right away, but then more and more kids were diagnosed, and the state, budgets were tighter. So they go home, they spend 8 hours on the phone trying to find the right person to get on the right waiting list and get the right paperwork in. Then they realize, I have 2 years to wait now, what am I going to do? They go on the internet, they find all kinds of information. There's often peer pressure I'm finding out about where, my friends have told me, God, I went to this parent support group and everybody was on my back that I'm not doing the GFCF diet. And even some national organizations say, you should try this exact therapy and just see if it works. And some of those therapies are really hard to implement, or you might not have the resources available to you. But as a parent, you feel really guilty if you haven't tried everything. And we as diagnosticians and ongoing service providers really don't do a good job of supporting families in the follow-up. We don't have care coordinators. We don't have people to kind of follow the families as they're making these decisions. And people like me, I'm not even all that available to talk to on the phone. I'm busy. So if you get a hold of me at the right moment, then you're lucky and I'll talk to you. But if I'm not available, it's really hard. I was thinking about what's a good model that we could use for the kinds of coordination that families of kids with autism need. And I was thinking the only service that really does this is hospice. And by that time it's over. You're not going to get out of hospice mostly. So we as Americans kind of don't do what we need to do until it's too late. Someday we'll get a big pot of money to be able to do care coordination. But for now, we'll just have to go with what we know. So autism is a heterogeneous disorder. We have very diverse outcomes across the spectrum, from kids who are completely nonverbal with, severe profound cognitive impairments and low adaptive skills to very high IQ and superior vocabularies. In the past, people used to think, the majority of kids with autism had intellectual disabilities, but now it's really probably less than 50%. I found, though, that with my families I was initially diagnosing, they really didn't realize that there was such a high rate of cognitive impairments with their child's with autism. So it's kind of like a double whammy. First, they get the autism diagnosis, then they find out that their child's significantly behind where they should be in development, and that's almost harder to take than the autism diagnosis. The social impairments also are diverse. We don't really have a great measure of severity of autism as much as we talk about, what's severe, what's mild. That's often parents' first questions. Where is he on the spectrum? We don't know what average autism is. So it's really hard to say where someone is on the spectrum. It's often defined in terms of your IQ and your language level, but not so much on what your social impairment is. I had a really brilliant guy that I used to work with, high IQ, but his autism, I would say, was pretty significant. I would say, hey, Dan, how's it going? And he would say to me, Solomon B. Chase. And I would say, what? And he loved U.S. secretaries of the Treasury, so he would just kind of come up to people in mid-sentence about U.S. secretaries of the Treasury and talk at length about them. And so I was totally confused. And this other guy, Rayhan, who also was very smart and had autism, a little bit less socially affected, said, oh, don't listen to him. He's just talking about U.S. secretaries of the Treasury. He loves to do that. So both those guys had autism and similar IQs, but clearly one was a little bit more socially appropriate than the other. There's been attempts to sort of define the social characteristics of kids with autism. There are a couple personality profiles, if you want to call them that. One is kind of the avoidant, passive, indifferent type of kid who just sort of seems really in their own world and sort of shut off from people and not very responsive. And then there are some kids with autism who are almost overzealous in their approach. So they go up to everybody sort of indiscriminately, but it's often inappropriate, like Dan and his U.S. secretaries of the Treasury. So autism has been around since, I think, the 40s. Well, it's been around since before then, but we've known about it. but we're still really learning a lot about how to treat it. There's no drug for autism. Maybe there will be, based on what Randy was talking about, but at this point, there's no drug to target the core features of autism, the communication and the social impairments. So to help guide researchers and practitioners, back in the late 90s, a committee of experts was convened, which was initiated by the National Academy of Sciences, and this was all distilled into a book called Educating Children with Autism, which is edited by Kathy Lord. I should tell you, Kathy, I used to work for Kathy, and she's kind of my mentor, so I'm a little biased about how great this book is. But it was a huge panel of experts, and they came together to sort of make sense of the treatments out there and how much research support there was for them. So these were the leading people in the field. They reviewed research that met certain criteria to be included in their review. So there had to be, in these treatments, enough description of the curriculum, or maybe even a manualized curriculum, so that it explained enough about what the treatment was for people to draw conclusions about it. So a lot of times when I'm reading articles about interventions, they say, oh, we did this, great, I don't know, vocational skill intervention, and then they don't tell you anything about what was in it and what the actual day-to-day treatment looked like. So it's really hard to know then what pieces worked, or if it was just some other thing that happened that led to better outcomes. So they also wanted to have studies that compared those specific interventions to other kinds of interventions, or to a comparison group that didn't get the intervention. So there had to be some sort of comparison group, not just everybody got the treatment, what happened to them. And they wanted to have large enough group sizes to see some sort of statistical effects. So a lot of studies on behavioral interventions have been single subject research designs, and it's really difficult to know if that's going to generalize to other children. So they looked at comprehensive programs that were giant packages, but also really wanted to see what the active ingredients were. Were there certain features that were consistent across these different programs that we might point to say, this is what's effective? So they wanted to have a systematic, a planned out way of reviewing these studies. They also wanted to look at treatments that had support from independent studies. So, I remember seeing Gary Mezeboff talk. He's a professor at North Carolina, has done a lot with the TEACH program. And he was saying you can either be an interventionist or you can be a researcher. But it's really hard to be both. So if you're an interventionist, all of your energy is going into the kids who you're working with and how to tweak it so that they're successful. And you really don't have, it's almost contradictory to your job to try to systematize things for research purposes and be, more neutral about it. So they wanted to have studies that had independent groups of people who did not, perhaps make money off the intervention, and compare the results from those. So the greatest number of well-documented studies used behavioral approaches, otherwise known as ABA approaches. There have been developmental approaches that have been documented with smaller sample sizes. I would say that the Denver model that Randy was talking about is one that we put under the developmental approach category, so there's a little bit more information, more support for that now. But really, there's not a lot of difference in terms of the strategies and the underpinnings of behavioral and developmental interventions, and they've become increasingly integrated. A lot of people think behavioral intervention means ABA or Lovaas. You're sitting at the table, you're doing discrete trial, you're getting, part of a gummy bear as a reward for doing the right thing. And that's not what behavioral is. Actually, if I if I were holding a cookie and didn't give it to my child until they said cookie, that's a behavioral intervention, right? So there's all kinds of, they're very integrated now. I remember there are some important differences, though, in how, concrete or direct the instruction methods are. So I had this family in Wisconsin who actually moved to Wisconsin from Canada to get the fantastic treatments available in Wisconsin. So that's really saying something if Wisconsin has better treatments than Canada. But anyway, this guy was a plastic surgeon, and so he was, very smart, and his wife was very smart, and their son was very smart, but had autism and some language delays. So they enrolled him in the Full Tilt 40-hour-a-week Wisconsin Early Autism Project, which is an ABA behavioral approach. And he quickly mastered all of their lessons. And I kept saying, get him away from the one-on-one instruction with the tutor. Like, do that 15 hours a week, and then put him in a really good daycare, because he needs to be around typically developing kids. He's got the language now, let's do that. And the dad said to me, I think ABA is like communism. It lifts everybody to a certain extent, but then you have to do something else to get farther. So I don't know, there's negative connotations with communism that I don't want to have applied to ABA, but I thought that was sort of an interesting way of describing it. So what were the characteristics that they found were critical to effective intervention? Number one, and this all comes from Educating Children with Autism, which you can get online, at this website, and you can get the whole book. I mean, it's annoying because you have to download each page, but you don't have to pay for it. So the critical features are entry into intervention early, really at the first sign of a problem. We're even moving that back now, just looking at kids who are at risk for autism and pouring on intervention before they show the full diagnostic spectrum. In the studies that have been included in the research, usually early intervention means before you turn 4. You need to be actively engaged in instruction for at least 25 hours a week, 12 months a year. And so I'm going to say this more than once, but it's not necessarily the placement of the child, but what you do with them. Okay, so not where you put them, but what that program involves. It needs to be active engagement. They need to be goal-directed, systematically planned activities. Even your free play needs to be planned with a goal. So there should never be a time, say you're running a really beautiful autism preschool program. There should never be a time where kids can just wander around and, stim or hand flap or do whatever. Even free play needs to have a goal. So maybe the goal is you're increasing their toy play. So the goal is that they make a new choice for a new toy. Or maybe it's turn taking that they're going to do during free play in a less structured setting. Or maybe it's peer interactions. It's not going to do you any good to have a child in an autism classroom if they're just parked there and it's glorified babysitting. And then it needs to be developmentally appropriate. So things that are typically mastered by that age group. And that's really important. You kind of lose sight of what typical kids do if you spend all your time with kids with disabilities. And that's one thing that I didn't really get in my formal education. We focused so much on kids with disabilities that when I went out into the field, I kind of didn't know, what do kids actually do at this age? So that's an important component to put somewhere in your training process. One example is my friend Rebecca has a child with autism named Justin. And Justin was actually the first kid I ever diagnosed. He, at age, I think it was 3.5 or 4, had a behavior program on tying his shoes. And he wasn't doing very well, and they were getting sort of frustrated with him. And then Rebecca, for some reason, went to a kindergarten classroom and saw almost every kid getting their shoes tied by the teacher. And she's like, he's not even supposed to be doing this yet. So, yeah. And then ongoing program evaluation. That's basically another term for database decision making, which is hugely popular in Minnesota. I'm also going to say many times that you need to follow your interventions closely, and if they're not working, if you're not seeing something great happening after 3-4 weeks, then you need to change what you're doing. So another critical feature that I want to emphasize is this beautiful quote: to the extent that it leads to the specified educational goals, children should receive specialized instruction in settings in which ongoing interactions occur with typically developing children. Okay, so again, proximity to children is not an intervention. Kids with autism don't learn as much through observation as typically developing kids do. So that means you need to have, if you're going to have an inclusive program, which I think are great, you need to have adequate supports and resources. So if you're enrolled in a general education classroom, you're a child with autism, and maybe you have some needs in terms of receptive language or behavior, you need to have extra supports in there, maybe a paraprofessional, maybe a co-taught classroom with the general and special ed teacher, so that that child can be successful. You also need to pull the child out as needed for intensive, maybe individualized instruction if it's a time in the general ed classroom when that child might not benefit. Okay, so I remember a kid in Michigan who basically was just forced to stay in the room. He would dart out of the room. And he was staying in the classroom for, whole group instruction in reading. And he wasn't talking yet and wasn't reading either. And so the whole time they were just corralling him onto the carpet and trying to get him to stay there. And it was totally, not anything he could benefit from. So it was like, why don't you pull him out right now and start working on your, language interventions or his functional communication skills, because this is not appropriate. But you also need to facilitate the typically developing kids in interacting with the kids with autism. So they might not naturally know how to respond to kids with autism or how to work a little harder to get them to interact. So all of that needs to be planned out. Okay, why 24 hours a week? So this doesn't happen in Minnesota or Wisconsin because people really do a nice job with special education in those two states. And in fact, I remember moving to Wisconsin and people were like, can you, write a recommendation into the report? These are school people. Can you write something in there so that I can justify giving him more services? And I was like, what? Because in Michigan, it was all like, no, we can't give any services because it's a much poorer state. But why 25 hours a week? So this doesn't have to come from a Birth to 3 program. It doesn't have to come from the school district. It just means that we need to have the kids actively engaged in 25 hours a week of intervention. Why 25 hours? Well, that was sort of pulled out because that's equivalent to a full year, full-time school program. So if you take out recess, lunch, things like that, it winds up being about 5 hours a day. We need to have that much time, and we need to have it through the summer because there's a lot of regression and recoupment. Because children with ASD really specifically benefit from the structure of adults. If they are left unstructured, they spend less time in social interaction. They're not as intrinsically motivated to engage in interactions with people as typically developing children are. They spend less time communicating, and they communicate about a narrower range of functions or topics. They spend less time in non-repetitive focused activities like play or something goal-directed. So, if left unstructured, they might, if they need something, go grab it on their own rather than communicating for it. They might, engage in some sort of self-stimulatory behavior or repetitive behavior, and those aren't going to increase their cognitive development and expand their opportunities for learning. I had a really well-meaning early childhood program in Michigan that just didn't have a lot of training, and they're sort of overwhelmed. And I remember walking in, and it was just really sad. There was a kid who didn't like a lot of light, so he was under the table, flicking his fingers in front of his eyes, and he was allowed to do that for like 20 minutes. So that's what that little boy would have chosen to do without some structured planning. So what do we want to have as goals for our educational services? And this applies to both, private agency intervention services and school special education public school services. So really, we want kids to have the same outcomes or goals as anyone, and that's personal independence and social responsibility. Being able to do what they want to do in the community. Now, that might not be the same for everyone, but we need to be looking more at kids' well-being rather than hard and fast outcome measures. So the initial studies looking at outcome have looked at things like full-time employment, living on your own. Some kids with autism might not ever achieve that. So how can we define well-being in a way that's meaningful? So a couple things off the top of my head are functional communication. That's something you need to be able to do what you want to do in life. And enough control over your behavior or your moods or your emotions so that you can accomplish your goals. Basically, it's about being in public without getting in trouble, without getting yanked or people looking at you or people asking you to leave someplace. And so what might that look like for your individual child? So some extreme examples. When I worked at Michigan, we had a boy come in who hated wearing clothes. Just hated it. And so we spent like an hour and a half battling with him to keep his clothes on. And he was 10, so he wasn't cute anymore to run around naked. And really, before we start working on math skills or whatever with him, he needs to keep his clothes on because he can't go anywhere if he's going to be naked. That's just the way it is. And then I had another little boy, less extreme example, who just really had a hard time with anything that wasn't in line with one of his rituals. If you turned left out of the driveway instead of right, 2-hour tantrum. It just really bothered him, and it was clear distress. It wasn't like whiny. It was just like he was really, really upset by this. So we needed to work on a way of building his tolerance and having less emotional reactivity so that, if he went out somewhere in public and some kid did something he didn't like, or they didn't get to stop at the fish tanks at Myers first, they had to go to the cereal aisle first, it didn't result in a big meltdown. So those are some goals I think that we need to focus on a little bit more, rather than words per minute reading, to get kids ready for independence in life. The role of families is also very important. Almost all of the empirically supported treatments that were included in educating children with autism had a well-defined parent component. So, parents can really do a lot to help their kids progress. This can take many different forms. In Michigan, where there were few resources, I'm just saying Michigan, Minnesota, and Wisconsin because that's really the only places where I've lived. So I'm not saying like Michigan is the model for bad and Minnesota, Wisconsin model for good. I'm just using my experience. So the level of involvement depends. There are some families in Michigan who really didn't have access. They were kind of rural. They didn't have a lot of ABA types of integrated programs available. So the parents went and received training on their own to be behavior therapists, basically. Some of them got that BCBA certification, and they implemented the full 30-hour-a-week program with their children. Others consult with another person who's a BCBA or a psychologist of some sort about doing some of the more parenty things like managing behavior or setting up routines at home that are conducive to the child's behavior and development. I think it's really important to involve parents on any sort of communication intervention because we communicate all day long, and it's important to reinforce that in every environment. There are some new therapies that I'll tell you about at the end coming up that really give parents a specific role for intervention at the earlier ages in terms of building relationships or building language through relationship-based interventions. So the active ingredients that came out of this big study, based on the review of comprehensive programs that had some evidence of efficacy. So these are the 6 kinds of instruction that really need to have priority in any intervention program for children, young children with autism. You need a functional, spontaneous communication system. I think we really need to think about that one. In places that are less sophisticated in working with autism, it's like, oh, you have autism, I'm going to do PECS. Well, PECS is great for some kids, but it's really clunky for other kids who have language. If I've seen kids actually go up and say, water, and then the teacher corrects them and has them pull out their PECS thing and stick it on the I want sentence thing. And it's like, what? How is that better than using your words? So, we need it. It needs to be functional. It needs to be spontaneous. It needs to build on what the child's already doing, something that they can use anywhere. They don't have to carry it with them, and only go to the things like the Dynavox and the PECS when you really can't produce that speech on your own or sign on your own. You need social instruction in various settings, definitely various settings. It needs to generalize. Play skills with peers, especially use of toys. Cognitive goals in natural contexts, and positive approaches to address problem behaviors. So a lot of that involves your basic behavioral strategies to be used with any child who has behavior problems. You're reinforcing what you want to see. You're ignoring or doing planned consequences for what you don't want to see. And then functional academic skills when appropriate. Some kids can be real math whizzes or awesome at reading and have very little language skills. So, in those cases, if they're already really good at those things, you might focus your special ed time on things like, functional communication or daily living skills, adaptive skills, and mainstream them for the academics if those are their areas of strength. Justin, the little boy I mentioned earlier, reads far better than he talks, so a lot of times his mom writes out what she wants him to do for the day rather than telling him. So the most studied intervention is ABA. So parents who are new to the diagnosis, often the first thing they hear is, you should get ABA. Your son needs ABA. And they kind of go, what's that? So it's a method, not a specific treatment. There's no one ABA book you open up and start working from. It's basically using behavioral techniques to teach new skills. Positive reinforcement, differential reinforcement. It clearly demonstrates to the child what the correct response is, and that applies to any sort of skill you're working on. And it also is very concrete about what the incorrect response is. Okay? So it's just breaking things down into smaller components and teaching in a very direct way that the child can understand, because a lot of them can't understand lengthy explanations, and teaching the behaviors you want to see. It focuses a lot on prompting and levels of prompts. So what level of assistance do you need to provide to get the correct response? It's important to fade those prompts as well, or else you become prompt dependent. I've seen a couple kids who won't sign until somebody comes and moves their hands to sign, even though they can do this on their own. They've just learned that the pattern is, I'm holding the cookies, somebody comes and pushes his arms together, and then he gets more cookies. Not that this means more, right? So fading prompts is really important. Actually, do you know that if you have on-demand on your Comcast cable, it's Autism Awareness Month. So there's all these little vignettes from the Discovery Health channel on autism. And I watched one last night on a little boy with severe autism, and he was in a separate autism school. And I felt really bad. It's probably an average situation. I felt really bad for him, though, because the entire time he had an adult on him doing hand over hand. And it didn't look like, it was edited, but it didn't look like he ever had a chance to do something first. Like it was time for him to take his tray over in the cafeteria. And it didn't look like they said, time to go, or take your tray. They just shoved his hands on it and walked away with him. And so that's not, you can do ABA poorly, right? But that's not what ABA is. Okay, Lovaas is the most studied method. The story of Lovaas. So what it often looks like is kind of that discrete trial training, or the sitting at the table and doing sort of one-on-one drill and practice. And they often start with kind of hierarchical skills that get you prepared for learning. So an initial skill might be coming to the table and sitting down and staying seated for long enough to be able to attend to another person. And then you build from there. Again, the correct response is rewarded. Incorrect responding might be ignored or corrected. Often focuses on elimination of problem behaviors. I don't know if anybody saw those original Lovaas films where I remember this is probably my undergrad psych, a little kid pounding his eyes, and he had detached his retinas, and they were doing behavioral interventions to get him to stop doing that. Usually provided at home, usually one-on-one. You earn your way into inclusion. So once you've gained a certain subset of skills, then you start applying it to group situations. So what this might look like, you might have an adult and a child sitting at a table, and you have 3 objects in front of them, and this is a receptive language task. You say, show me chip, and they hold up the chip. Okay, really simple example, but you can also build that into lots more complex skills. So Lovaas is often controversial because of some of the components of the Lovaas intervention that were initially around. But also the original Lovaas study, the one you often hear about, from 1987, it had 19 kids who got the Lovaas intervention and 19 who didn't. And they found that about 47%, quote, recovered. Now, they've sort of backed off from that word recovered, but what it really meant was that they had average IQ and Vineland scores, and their teachers described them as indistinguishable from other students. So follow-up studies found that the same group of kids maintained their best outcome results. And then when it was replicated and implemented in more of a community setting, so it wasn't done at UCLA, it was done by community service providers, they had higher IQ and adaptive skills, but their receptive language and nonverbal skills didn't exactly meet that best outcome status. So, you can get really positive results. One of the things I would ask about those recovered kids is they were really looking at IQ and adaptive skills, and they weren't looking necessarily at social interaction. Now, developmental approaches, on the other hand, these actually use quite a bit of behavioral strategies, but their focus is on natural environments and sort of these foundational relationship skills. You're following the child's lead, you're incorporating their interests into what you're doing, and the focus is on play and social interactions. There's some research on these approaches, but RCT means randomized clinical trials. There's not like a random group of kids who got this intervention compared to a random group of kids who didn't. Okay, so one of the most popular ones is DIR or floor time or Greenspan. Stan Greenspan sort of developed this form of training. And DIR stands for Developmental Individual Difference Relationship-Based Model. So that's a little bit, I don't know, they might want to work on that. So what this involves is you're building foundations for healthy development. And these are through making the child's interactions with their parents or with whomever meaningful and self-initiated. So floor time is different play activities the parent does on the floor or in play in natural situations with their child. Then there are problem-solving type sessions that involve setting up challenges for the child to solve to teach them something new. And that something new might be a way to communicate. So an example might be you put their favorite toy or their favorite food into a clear container that they can't open. Now they have to learn a new way of getting to that treat. And it might be going up to their parent and handing it to them, or it might be saying help, or depending on where the child is at. Floor time also incorporates individual therapies like speech and language therapy, sensory integration, any PT that might be needed. The educational program, again, you sort of earn your way into inclusion. And then they also support incorporating other interventions. So this is kind of like a name brand intervention, DIR floor time. And they talk about biomedical, nutrition, other sorts of treatment that have anecdotal support. Denver model we've talked about a little bit, uses this kind of theoretical background, and you want to bring the child back into the social milieu, they say. This has a lot of family involvement to carry out the strategies in different environments. And then there's time in an inclusive preschool. There's a lot of focus on imitation, communicating with others to get your needs met and to share interest, and building that intrinsic motivation to interact. Now I'm going to move on to things that I call blends, okay? Because these are neither really ABA, classic Lovaas, and they're not really classic developmental either. Pivotal response training, that PRT, pivotal response training, gets thrown around a lot. And it took me, I think I know a lot about autism, but it took me forever to figure out what the heck this was. People kept saying, oh, you should recommend PRT. Okay, what's that? What it is defining kind of foundational skills that cover the most targets at once. So these are some, it's not exhaustive again, but these are the classic types of skills that you want to build upon that will affect multiple areas of development. So the first thing you want to teach, using again positive reinforcement, is a motivation to interact. So teaching kids that it's actually fun. Maybe you really love this toy, but it's even more awesome if you interact with your mom with the toy, or if you interact with this other kid with the toy. And then they see, next time maybe they'll learn that it's more fun to bring someone else in. Responding to multiple cues is another one. Kids with autism often can really focus in on something very small, and you're calling their name or something else is going on, and they're not even aware. So you teach them to sort of look up and be aware of these other cues in their environment that are important. Self-regulation, being able to be in charge of your emotions, being able to initiate interactions with others. Verbal behavior is another one that's increasing in popularity. So I often hear, you should do verbal behavior ABA. And what this training program is, it's basically ABA, or behavioral strategies, classic Skinner behavior strategies, but applied to spontaneous communication. So Vince Carbone does some really nice workshops all around the U.S. He's got a really nice introductory one that I kind of like. But it blends the developmental into the behavioral, because in producing spontaneous communication, you start with what the child already loves. So, and you use that also to reduce problem behaviors. So I remember he had this nice video where this kid comes into the school and he's just screaming, he just hates it, he's having such a bad tantrum, and this goes on and on for weeks. And all they do is sort of walk him into this room with the trampoline. They stick him on top of the trampoline, and as soon as he stops, and it might just be to go like, before sobbing again, they bounce him on the trampoline. And so then he's, eventually learning, like, if he doesn't cry, this awesome thing happens. And so they build from there. Or, they have the thing of popcorn next to the movie. They stop the movie and they wait for the child to look at them or make a sound, and then they get the movie turned back on. So it's training them to use spontaneous communication to get what they want. There's a lot of emphasis on pacing. They do some discrete trial, but the pacing is really important. It has lots of jargon, like mans and tacts. So I don't know if any of you have heard that before, like parents, here's his manned graph, here's how many mans, so that just means requests. Tax means label. I don't know why they have fancy terms, but they do. Another example that's often used in schools is the TEACH method. That's looking at the culture of autism, what kids with autism, what their strengths and weaknesses are, and how to build upon those in a classroom environment. So how does a person with autism think and solve problems? How this often looks is it structures the environment to make it very predictable and to promote the child being independent in getting things done. There's visual supports, so you might have 3 jobs that the child has to do, and it could just be a worksheet, it could be, I don't know, a hygiene task, and you might have a red piece of paper that says job 1 and something on top of that, red piece of paper job 2, red piece of paper job 3, and then a bin with a green piece of paper in it that says done or work done or take a break. And so you complete the jobs. When you're done, you put it in the bin. When there's nothing else in front of you, you get a break. Okay, so really clearly showing you what the expectations are. We talked a little bit about, well, no, we haven't. So the LEAP and Walden incidental teaching programs are more inclusive programs that incorporate behavioral and developmental models. The Walden program is one I know more about. That's Gail McGee down at Emory. And this is a really nice program. So there's an inclusive preschool where there's maybe 50% kids with autism, 50% typically developing kids. There's actually a wait list for the typically developing kids as well as the autism kids, so that's great. And the typically developing kids are kind of trained to promote the kids with autism's communication. So they're increasing the amount of time the child is engaged in some sort of communication or learning task. So I remember a video she showed of this little kid is playing next to this kid with autism, and the kid with autism is just really loving the Ernie doll, and he's not doing too much with it. And the other kid takes the Ernie doll and just holds it over here, and then the little boy with autism is like, Ernie, and then he gives it back to him, and then they have like a little to and fro about it. So it's not enough for him to just hold it and give it to him, then they engage in an interaction, but there's some intentional communication built in there, and kids can do that. What's difficult about those inclusive programs is that the training of the typical kids doesn't generalize to a new classroom. This is not necessarily natural for any of us to know how to best interact with a person with disabilities. So you end up having to train the new class of kids every year. School programs that are typical, I just kind of wanted to put this up there to just sort of say what often happens once you enter school for a child with autism. A lot of them go on IEPs if they need it. Not everyone with autism does. They often have collateral skill interventions, direct therapy for speech, OT, developmental adaptive Phy-Ed. Behavior supports are common. Some schools have developed autism-specific classrooms that maybe implement a TEACH model or a LEAP model. And transition planning is really important. One thing that a lot of parents complain about is once you hit high school, it's over. There's not a lot for you as a child with autism. So there is some research going on looking at comparing different ASD programs to one another. So I know David Mandel in Philadelphia is implementing like a STAR intervention program in half the schools and a TEACH, I think it's TEACH, in the other half of the schools, and the classrooms are randomly assigned. So that's really exciting. Now we're starting to get people researching comparing one treatment to another. In the past, it's often been you're implementing a comprehensive program and comparing it to, quote, eclectic, like just whatever you feel like doing, or a blend of lots of different things. One of the questions that we have yet to answer is first of all, how far do we drift from the program purity? So, Lovaas' program at UCLA, they have Ph.D.s all over the place. They have a specific training program. They only get grad students to do it. If you distill that out into the community, there's only so many Ph.D.s to go around, and you get a lot of turnover. So what kind of drift happens? And how much fidelity or how much do we need to stick to that script to have the same effects? So like I said, ABA can be done badly. All of these programs can be done badly, and we don't know if they'll still have an effect. So simply having 3 pieces of paper with job 1, 2, 3 doesn't mean you're doing TEACH. Okay, there's more to it. And we don't exactly know what kind of teacher training is best or if there are individual factors that are best. I'm a ADOS trainer. ADOS is a diagnostic measure, and I train tons of people on it. And there are people, nobody you would know, but there are people I've worked with in the past that I thought, they just shouldn't give the ADOS. They're just not, they don't have it. They're not natural. So, you always think people can be trainable, but some people just don't have the knack. Complementary treatments. So these are things that have some anecdotal support. If there were larger evidence-based studies on them, they haven't shown support, like diets have been compared to no diet and have not shown group-level effects. But there might be individual children who benefit from these things. These are things that are out there. You can find them on the internet really fast. Parents kind of go to them hoping that they'll find this one magic thing. I was listening to NPR last week, and there was a family of 8 kids, 5 of whom had autism, and they did this music therapy, and lo and behold, their nonverbal 5-year-old started talking. I always am skeptical of treatments like that because, if you've worked really hard with kids who aren't talking, you know that it's not just some switch that flips. But, if it works for your kid, keep doing it. So what's effective? We can't just address a simple question about whether a practice in special ed is effective. You have to say for whom the practice is effective and in what context. So in other words, no one thing is going to work for everybody. So active ingredients that we've identified throughout these comprehensive programs that we know to be in programs that work: frequency, duration, and intensity. So having regular therapies that have a long enough duration and a high enough intensity that meaningful skills are developed. So a criticism of birth to 3 is you're not going to get anywhere with an hour a week of speech if you have autism. That's true. Birth to 3 was not developed, though, for kids with autism. It was developed for kids who might have, they need some school readiness skills, and maybe that group of kids can benefit from that level of intervention, but kids with significant disabilities can't. So we need to do something else. Database decision-making, training and ongoing support, not just for the teachers, but for families. Fidelity of implementation. Funding is really important. It's really hard to do something without money. I hate it when people say money can't solve the problem. It's like, well, it's kind of necessary. So one of the things about autism is that there's a lot of variability in outcome. So if we look at the group level, so this is a group of kids. The black dots are autism, the stars are kids with PDD diagnoses, and the open squares are kids with non-spectrum disabilities. So over time, if we're looking at language development, you can see the kids with autism, They keep making progress, but it's significantly lower than the other two groups. What's interesting is the non-spectrum kids start to level off. They're making fewer and fewer gains as time goes on. The PDD kids, have a pretty nice trajectory. But if you look at the individual level, so these are all kids with autism. Each line is a different kid. So you can see the extreme spread there. The dotted line is average. And you can see there's a lot of clustering at the bottom of kids with autism who don't make a lot of language progress, and that might be the kids who are still nonverbal. But there are some kids who make so much progress they're well above average. We also can't predict whether getting treatment at the individual level is going to necessarily lead to outcome. So here's a kid who has clearly speech-language impairment in addition to autism, doesn't get much intervention. So this is a kid from Michigan. Here are his ADOS scores, which higher score means worse social behavior, worse repetitive behavior. And you can see he sort of stays up there, which might be something we'd expect because he didn't get intervention. Here's another kid, got intensive verbal behavior intervention. And actually, it's not significant. It's not like he got worse on the ADOS, but he didn't really change either. So what do we need what predicts an individual's response, basically? Most of these studies of outcome have looked at IQ or special ed placement as the outcome. But where you're placed in special ed doesn't necessarily depend on you as an individual. It often depends a lot on what your district is like. So there's a little bit of research starting to look at this. There's one study that was really good trying to predict what sorts of factors beyond IQ or language level would lead to kids responding to intervention. So this is a small study Sharon Schreibman did, but they took 6 kids, 3 of whom they thought would be good responders, and 3 of whom they thought would not be good responders. And this was based on these skills down below. So having toy play, functional toy play, these are kids under age 4, having social approaches to others, being low on avoiding other people, doing a lot of verbal stimming, so making a lot of different complex sounds or maybe even some stereotype speech, and then being low on nonverbal stimming, so sort of repetitive motor mannerisms. And they found that what they predicted was true. The kids who were thought to be responders did respond better and make more gains. Other predictors that we know of are joint attention skills, expressive language, particularly by age 4 and 5. How many initiations you're already making on your own. So if you're a child who's already seeking out other people, chances are you're going to build faster than a child who needs to be motivated to do that first. So there's also a new area of intervention that's coming out for kids who are at risk, perhaps not fully diagnosed yet. We do this for kids who are baby siblings of kids with ASD or who are showing some red flags in the first years of life. And what we're sort of thinking about is, diagnoses are hard to get sometimes, especially before you hit school. So is there something that we can do at the screening level when we see that there are signs of concerns but maybe not a diagnosis, and then do whatever we need to do for insurance or waiver purposes to get them enrolled in intervention? These tend to be parent implemented, so the parent integrates different strategies into their daily interactions and communication with their children. An example is the More Than Words curriculum out of Canada. There's a couple programs being researched right now. One's looser early social interaction study that Amy Weatherby at Florida State is the author of, and that involves really integrating communication and natural interactions to a social routine and a play routine every day. And then the Denver model is also being adapted to little kids working on parent training to build imitation skills and joint attention. So that's kind of a new area that we don't have a lot of information on, but the hope is that we can instill a good amount of skills into kids early that might mitigate some of the effects of autism. We don't know if we can prevent autism, but the hope is that we can build skills earlier to give them more positive outcomes. So I just put up some websites for more intervention. I'm not advocating anything on all these websites, but these are some good ones that have comprehensive information and some nice resource packets. And then I just want to thank you for your time, and we're at the University of Minnesota if you want to contact us and ask any questions or, find out more information. So thank you.